looks like we're at the top of the hour, so I want to welcome everyone today to our webinar on strategies and techniques for blood pressure management, blood pressure competency training. We appreciate that everyone has joined us today to learn about this really important skill. My name is Jerry Henniker. I am a program manager and a quality improvement advisor at Superior Health Quality Alliance. One thing I do want to say before we get started here is that we are recording this webinar, so just wanted you all to be aware of that. Our speaker today is Andrea Boucher, who is a program manager at MPRO, which is a partner in the Superior Health Quality Alliance. She has worked on various CMS priority initiatives, including improving cardiac health and increasing diabetes self-management. She has worked at MPRO for over 8 years. Her areas of expertise include wellness and health promotion, patient education, and chronic disease self-management. Ms. Boucher earned her master's in health services administration from the University of Detroit Mercy and a Bachelor of Science in wellness, health promotion, and injury prevention from Oakland University. She is a certified professional in healthcare quality. Just a few housekeeping details, and then I'm going to turn it over to Andrea. Just wanted you all to know that we will take questions at the end of our webinar today. If you have questions that you would like to ask, you can enter them either in chat, and we'll make sure that those get asked at the end, or you can just hold your questions and ask her live at the end of the presentation. And with that, I'm going to turn it over to Andrea.
Great. Thanks so much, Jerry. As Jerry said, my name is Andrea Boucher. I'm really excited to be here today to share with you some strategies for proper blood pressure measurement in your facility. I'm sure many, if not all of you, are probably responsible for taking a patient or a resident's blood pressure every day. So although this might feel like a refresher for you, it is always good to revisit this information at least once a year. So I'm hopeful that you can take some tips and tricks today back to your practice or your facility that you can start implementing now. And I do see that we have participants joining us from a variety of different settings. So just understand that the technique that we will be discussing today is really the gold standard. If you're coming maybe from the nursing home setting, for example, it's understandable you might not always be able to get a patient or a resident into a chair for blood pressure measurement if that does increase the likelihood of a fall risk. So whenever it is possible, it's recommended to do the proper technique that we will be discussing today. But again, take this on a case-by-case basis. So just to quickly go over our objectives for today, we will be reviewing the techniques required for accurate measurement, and this will hopefully strengthen the techniques in your staff that are measuring patients' blood pressure. We will be talking through the blood pressure thresholds and then also reviewing some hypertension management strategies and resources. But I really wanted to make this session interactive today. So if you do have a pen and paper handy or close to you or some way to jot some numbers down, go ahead and grab that. As part of the presentation, we're going to be playing a scavenger hunt game throughout. So periodically, I'll be asking you some questions just to notice some things about yourself and your environment. And then I'll tell you how to score them appropriately. So keep tabs on those numbers and we will tally them up at the end of the presentation. So just like golf, the lower the score, the better. So first off, for our scavenger hunt item number 1, we would like to know, are your feet on the ground and your ankles uncrossed? If not, if your ankles are crossed or if your feet are not supported on the ground, you can give yourself 10 points for item number 1. And I know I am definitely guilty of that one. I tend to sit Indian style as I work on the computer. All right, so before we dive into proper blood pressure measurement technique, we want to just take a moment to talk about why proper measurement is important with a little bit of a background. So let's take a look at some blood pressure facts. 1 in 3 Americans has high blood pressure or hypertension, and it's more common among some population groups. This includes African Americans and adults over the age of 60. And high blood pressure is also known as the silent killer because most people do not show any symptoms. There's also a connection to chronic conditions. more than 65% of adults with diabetes also have high blood pressure. More than 20% of people 20 years and older who have chronic kidney disease, and 74% of people with chronic heart failure have high blood pressure. And then also, again, with patients with diabetes, they are at higher risk for hypertension. So this slide highlights the consequences of high blood pressure on the body, especially if it is left untreated. So just kind of starting from the top and working our way down, stroke, high blood pressure can cause the vessels in the brain to burst or clog. It can also lead to vision loss due to the strain on the vessels in the eyes. It can also lead to heart failure. Causes the heart to enlarge and fail to supply blood to the rest of the body. Heart attack, which could damage arteries and cause blockages. Kidney disease, which can cause damage to the arteries around the kidney. And then also sexual dysfunction in both men and women. So really, blood pressure checks are that first step in identifying patients with high blood pressure and could ultimately avoid these potentially deadly consequences. So, why is it important to screen patients for high blood pressure? Obviously, you want to identify patients with uncontrolled high blood pressure. Maybe you have patients who might not be aware that they have high blood pressure. Again, high blood pressure does not always present with symptoms, so this could go unnoticed by a patient. Or maybe the patient is aware that they have high blood pressure, but they're not managing it properly and their blood pressure is not in control. It also helps to prevent complications and improve outcomes when patients are routinely screened for high blood pressure. So, checking in again with scavenger hunt item number 2, are your legs uncrossed? If they are crossed, you can go ahead and give yourself 6.5 points for item number 2. So, screening is really just the first step in managing a patient's hypertension. We cannot diagnose or treat a patient's high blood pressure correctly if we're not capturing them correctly through measurement. So, making sure that we take patients' blood pressure correctly on every patient every time is really essential. So these accurate measurements lead to that correct diagnosis. The blood pressure reading is used to initiate treatment for patients with high blood pressure and monitor the effects of drug therapy if a patient is placed on a medication. It also allows the patient to have timely and effective treatment, so making sure a patient does receive that appropriate medication in a timely manner. And then also routine monitoring. If a patient is diagnosed, making sure that they are continuously monitored throughout the year. And then medication adherence. So if a patient is prescribed an antihypertensive medication, that they are being screened for blood pressure, letting the clinician see if the medication is working properly, or if the patient is taking that medication correctly. Inaccurate blood pressure readings could have potentially damaging impacts on patients. If a blood pressure is missed elevated, or it's one that's underestimated or misclassified, that could be interpreted as a false normal level. So that could ultimately lead to undertreatment, which could then lead to even further organ damage for that patient. If the blood pressure is overestimated or you're looking at a false high reading, that could lead to overtreatment and the possibility of drug-induced side effects if the patient was placed on a medication that they didn't necessarily need to be on. So that's why it's really important to use proper techniques so that your readings are consistent and reliable. So this slide outlines a few things that impact a patient's blood pressure. On the left-hand side, we're looking at patient factors. Those are ones that are not always in our control. And then on the right-hand side, the measurement factors. Those are going to be what we're focusing on in today's training, things that we can control. Just quickly going over the patient factors, a patient could experience white coat hypertension. Maybe a patient is feeling anxiety in the medical environment. That could lead to an abnormally high reading when their blood pressure is being measured. Kind of going in with that next bullet, if they are experiencing any nervousness or stress, illness, pain, long waiting time, all of those experiences could also lead to an elevated reading. Certain patient demographics, age, sex, race, and ethnicity, certain population groups may have elevated blood pressure readings. Also, a patient's lifestyle. Obviously, we can make lifestyle change recommendations, but if a patient has poor diet or exercise habits, if they are using substances such as smoking or alcohol use, this could also impact their blood pressure. And then looking more at on a specific day when you are taking a patient's blood pressure, if they have recent caffeine intake, have taken a decongestant or an over the counter medication, or have smoked or used nicotine before their reading, that could also elevate their blood pressure. And then lastly, talking. We can't always control whether a patient talks during a reading, but that can also elevate the reading. So now looking at the measurement factors, patient positioning is very, very important. That's one area that I'm really going to hit home today during this training, making sure that a patient is positioned correctly, because if they're not, that can definitely have a major impact on their reading. Making sure that the blood pressure cuff is fully deflated before putting it on the patient's arm. If there is any air in the cuff, that could elevate a patient's reading. Proper cuff size. If a cuff is too large, that's going to underestimate their blood pressure. And if it's too small, that's going to overestimate a patient's blood pressure. Making sure that the cuff is wrapped evenly around a patient's arm so that it doesn't come undone upon inflation. Deflating the cuff too quickly can also be a measurement factor. We typically say to deflate at about 2 to 3 millimeters of mercury per second if you're using the manual technique. That does sound really slow, but that way you are accurately capturing those systolic and diastolic readings. Not inflating the cuff high enough or too high. So this is making sure you're not just blanket inflating all patients up to a specific level. And this is where the maximum inflation technique comes into play, and I'll cover that in a little more detail in a couple slides. The auscultatory gap. So this is when the pulse disappears and then it reappears while you're deflating the cuff. So if this is not interpreted correctly, this gap could lead to blood pressure monitoring errors. So this namely could be an underestimation of systolic blood pressure or an overestimation of diastolic blood pressure. So for example, maybe you hear the first pulse sounds at 220. There could be a disappearance until it picks up again at, say, 140. So making sure you capture that systolic correctly at 220, the maximum inflation technique can help resolve this, and we'll cover that in a few slides. And then looking at the gauge at an angle. So again, if you're using the manual technique, making sure you're able to see that gauge correctly. So this slide just covers the blood pressure level thresholds. These were updated, I believe, in 2017. So what is classified as normal is now a systolic of less than 120 with a diastolic of less than 80. What is considered elevated is a systolic reading between 120 to 129 and a diastolic of less than 80. And then stage 1 hypertension is now considered systolic 130 to 139 or diastolic 80 to 89. Hypertension stage 2 is 140 for systolic or higher, and then 90 or higher for diastolic. And then what is considered a hypertensive crisis is anything that is systolic higher than 180 or diastolic higher than 120. So I just wanted to quickly get a gauge on all of you. This is a pop quiz. Don't worry, it's not graded. Does an elevated systolic or diastolic value put individuals at greater risk for complication? So you can feel free if you'd like to answer that. You can add a response in the chat box. I'm seeing some answers rolling in. I'm seeing a diastolic. And it is diastolic. So if you have an elevated diastolic value, that is more greater risk for complications, since diastolic readings are when the heart is at rest. So great job, everybody. Time for scavenger hunt item number 3. Is your back supported? If you're seated but your back's not supported, you can go ahead and give yourself 5 points for item number 3. So now that we know the why of the importance of accurate blood pressure measurements, we will walk through the equipment that's needed. At your facility, you might have different types of blood pressure equipment. So we'll cover each of those and how you can use those to get accurate blood pressure readings. So there's multiple options for equipment that can be used to measure a patient's blood pressure. In general, the gold standard is going to be devices with the upper arm cuff. And here we've summarized manual, semi-automated, and automated devices. The top two on this slide show the two manual devices, one that is portable and one that is mounted to the wall, which is typically seen in patient exam rooms. These devices, you will be inflating the cuff using the inflation pump, and you'll be using a stethoscope to listen for Karate cough sounds that are associated with those systolic and diastolic values. The automated and semi-automated devices are really easy to use, and those can be helpful in reducing the chances of human error. With a semi-automatic device, the user has to inflate the cuff manually by hand using the bulb, like the conventional device. And once it's inflated, the device can then start deflating, and the cuff will automatically deflate. And beyond that point, that reading is produced in a similar way as an automatic device. For fully automatic, it has an electronic pump for inflating the cuff. The operation of that device is really very easy to use and requires minimum input from the user. Once the cuff is placed on the patient's upper arm, the device can be switched on, and then the readings are produced automatically. So this can reduce the possibility of white coat hypertension, as the clinician could leave the room and multiple measurements could be taken. So it's also really important to make sure your devices are validated for clinical accuracy and that they are calibrated periodically. So this means that the device is being tested to make sure it's producing accurate readings. For manual devices, it's recommended that calibration should be every 6 months. One way to quickly see if a manual device is not calibrated is if the dial of the gauge is not resting at 0 when the cuff is fully deflated. The automated and semi-automated devices should be calibrated on an annual basis. And here you could reference the device manual to see if your staff is able to calibrate these devices themselves or have the devices calibrated by the manufacturer. So we've talked about the different types of blood pressure devices. We also need to know the components that make up a blood pressure device. So what you will need to measure is your blood pressure cuff. For manual devices, this includes the inflation system of the device, which is the cuff, the inflatable bladder inside of the cuff, the inflation pump, and the pressure control valve, and a calibrated sphygmomanometer gauge. If the sphygmomanometer gauge is defective, this could lead to inaccuracy, and you want to make sure that your device is calibrated before you take any measurements. You could also have multiple cuff sizes available, ranging from pediatric sizes to large, extra large. If you have a thigh cuff available, that could also be used in the event that you do need a larger cuff. And then you'll also need a stethoscope for the manual technique. So scavenger hunt item number 4, are your arms supported at heart level? If one or both of your arms are not supported at heart level, you can go ahead and give yourself 10 points for item number 4. So as I mentioned, accurate readings are really the basis for identifying and managing patients with high blood pressure. So now we'll walk through the recommended steps for measuring blood pressure just to make sure the care team is using a consistent technique to get those most accurate readings possible. And we've broken these down into 10 easy steps, but this is dependent on the type of device you're using. If it is automated, there are going to be less steps involved in this process. So step number 1 is to choose the right equipment. So what you will need is a quality stethoscope if you're using a manual device. Whether you're using manual or automated, you will need an appropriately sized blood pressure cuff per that patient, and we'll cover how you know that's a proper fit in just a second, and then a blood pressure measurement device. So, step number 2 is to prepare the patient. Like I mentioned, patient positioning is very important regardless of what type of device you're using. So, before you're measuring, you want to allow the patient some time at rest. 5 minutes is typically what's recommended. This is just to make sure that the patient has um, been given some time in case they've just walked in from the lobby, that their blood pressure can have some time to return to normal. So, have the patient seated as they're taking their blood pressure, and we'll walk through each of these bubbles really quickly. So, using the correct cuff size. If you are using a cuff that's too small, this could add 2 to 10 millimeters of mercury to the patient's reading. You also want to make sure you are placing the cuff on the patient's bare arm. If it is placed over clothing, this could add 5 to 50 millimeters of mercury. It can also make the pulse sounds difficult to hear if they're using the manual method. And also, if I know we we live in the Midwest, it can be cold in those winter months. If the patient is dressed in layers and is just able to roll up their sleeve, you want to make sure that it's not being too restrictive up at the top. So make sure you are able to slip about 2 fingers into the sleeve of their clothing if they are rolling it up. And then supporting the patient's arm at heart level. If it's unsupported, this could add 10 millimeters of mercury. Often, these patient positioning factors will depend on the setup of your exam room or wherever you're measuring a patient's blood pressure. It is best if the patient is seated in a chair with an armrest, or maybe there's a tabletop next to the chair. You can also use your waist to support the patient's arm. You just want to make sure that the patient is not supporting the weight of their own arm as you're taking the measurement. And then make sure the patient is seated with their legs and ankles uncrossed. If they are crossed, this could add 2 to 8 millimeters of mercury. And while the patient is seated for the measurement, make sure that their back and their feet are supported. If that is not addressed, this could add 6 millimeters of mercury. And then making sure that the patient has an empty bladder. If let's say the patient needs a urinalysis during their appointment, I would recommend try doing that first so that they don't have a full bladder during their reading. Because if they do, that could potentially add 10 millimeters of mercury. And then making sure there are no conversations going on in the room. If they are talking or even actively listening, that could add 10 millimeters of mercury. So, these patient positioning techniques should help you get an accurate blood pressure reading, whether you're using the automated or manual method. So, no matter what way you're doing it, try to make sure that these areas are addressed. Step 3 is to choose the proper blood pressure cuff size. So, I had mentioned a few times that if the cuff is too large, that's going to underestimate a patient's blood pressure. If it's too small, that will overestimate the blood pressure. So, to make sure you choose the correct size, you can see from this slide that there is an index line on the blood pressure cuff. It runs along the width of the cuff. So, as you're wrapping the cuff around a patient's arm, you want to make sure that that line is falling within the range that you see at the top of the cuff. So, that lets you know that that cuff size is appropriate for the patient. If the cuff falls on the inside, that index falls on the inside of the range, you know that the cuff is too big. And then if it falls on the outside of the range, you know that the cuff will be too small. This slide is just for your reference. It is the blood pressure cuff dimensions by arm size. I don't expect you to go around with a tape measure and measure patients' arms, but just a note to say, if you notice that a large or an extra large cuff is still too small in a patient, you do have the option, if you have it available to you, to use an adult thigh cuff on the upper arm. All right, scavenger hunt item number 5. Are you dressed in layers? If you're wearing layers that cannot be removed from one or both of your arms, you can give yourself 27.5 points for this item. And then going into step number 4, placing the blood pressure cuff on the patient's arm. So here you want to palpate or locate where the patient's brachial artery is at the crease of the arm and position the blood pressure cuff so the artery marker on the blood pressure cuff is pointing down towards the brachial artery. And then you will wrap the blood pressure cuff snugly around the patient's arm. We do have a couple of 2-finger tips or rules here, making sure that the cuff is snug but not too tight. So you can have 2 fingers width above the crease of the arm. So this gives you a place to put your stethoscope if you're using the manual method, so that you're not putting the stethoscope underneath the blood pressure cuff. And then 2 fingers should fit between the arm and the snugly wrapped cuff. So that way you're making sure it's not wrapped too tightly or too loosely. So another pulse check pop quiz question, which arm should be used to measure blood pressure? And you can feel free to drop a response to that question in the chat box. So do you think it's right? Do you think it's left? Is there not a recommended arm that should be used? See some responses in the chat coming in. All right. So it's almost a trick question. The correct answer for this is at the patient's very first visit with you, you want to check a patient's blood pressure in both arms if they are able. After checking in both arms, you want to use whichever arm was giving a higher blood pressure reading at subsequent visits. So if, for example, a patient had higher readings in their right arm on their first visit with you, you would use that moving forward. All right, so step number 5 is positioning the stethoscope. So on the same arm that you placed the blood pressure cuff, you palpated the brachial pulse at the crease of the arm, and then you will place the diaphragm of the stethoscope over the brachial artery at this location. And step 6 is determine the maximum inflation level. So I have mentioned this a couple times. This is known as the auscultatory palpatory technique. And this is a technique for you to use to determine how high you should be inflating the cuff if you're using the manual technique. So like I said, this is so that not all patients are just blanket inflated up to a number, let's just say 200. If a patient typically has a lower systolic value, they don't necessarily need to be inflated that high. And that could help maybe make the patient feel a little more comfortable. Also, if the patient had a systolic value over 200, this would accurately capture that. So you have a couple of different options with the maximum inflation level. The first one is to inflate the cuff as you're listening for the brachial pulse. So here you have the cuff on the patient's arm, the stethoscope is located over the patient's brachial artery, and you're going to slowly inflate the cuff until you hear the pulse sounds disappear through the stethoscope. You're going to look at the gauge and note that number where you heard the pulse sounds disappear, and then inflate 20 to 30 millimeters of mercury above that level, and then you can deflate to take your reading. Option 2, you won't be using the stethoscope yet. You will have the cuff on the patient's arm. Inflate the cuff as you're palpating the radial pulse. And until you feel the pulse disappear, note that gauge reading. And then as you're taking the blood pressure, you would go 20 to 30 millimeters of mercury above that level. All right, checking in for scavenger hunt item number 6. Are you talking? If you're having a conversation, give yourself 6 points for item number 6. All right, then step number 7 is slowly deflate the blood pressure cuff. If you are using automated or semi-automated, this will be done for you after you press the start button. But with the manual technique, you will begin deflation by gently loosening the thumb valve. Again, you want the pressure to fall at about 2 to 3 millimeters of mercury per second. And this is just to make sure that you're noticing the cough sounds at that right systolic and diastolic levels. Step number 8 is to listen for the systolic reading, and that is the first occurrence of pulse sounds heard as blood begins to flow through the artery. And that systolic is the top number, which represents the pressure in the blood vessels when the heart is beating. Step 9 is listening for the diastolic reading. So the diastolic reading is when the last pulse sounds are heard before all sounds disappear. Diastolic is that bottom number, and that is representing the pressure in the vessels when the heart is resting between beats. And step 10 is double check for accuracy. So if a patient's blood pressure is over 120/80, it's recommended to take a confirmatory measurement just to determine if the patient's blood pressure is in fact elevated. Um, you want to note the individual readings as an average, and it gives you a snapshot. So some of the automated devices will do that for you. They will give you each individual reading and then also give you a summary of all of the readings as an average. You want to make sure you're waiting about 1 to 2 minutes between readings, because as you are inflating the cuff on a patient's arm, that could also elevate it a little bit. So you want to make sure you're letting them come back down to baseline. And then scavenger hunt item number 7. So, pardon the inquiry, but do you need to use the restroom? If you do have a full bladder, you can go ahead and give yourself 10 points for item number 7. So, we've walked through the steps to properly measure a patient's blood pressure. What we will be covering next is just some hypertension management strategies and resources for you. So, a little bit of a background about diagnosing hypertension. This must be done based on multiple elevated readings. You can look at a patient's medical history to see if they've had multiple elevated readings from previous visits, or if this is their first elevated reading, you want to make sure that that patient is being seen again in about 1 to 4 weeks to confirm a diagnosis of hypertension if they have an elevated reading at that future visit. So, a best practice for identifying, treating, and managing hypertension is to implement a blood pressure protocol. This helps to ensure that clinicians are diagnosing and treating hypertension in a standardized way, of course, with exceptions based on their clinical judgment, and that these recommendations are staying up to date. So, this is a tool from the American Heart Association and the American Medical Association. It's something that your team can refer to for a treatment protocol. Within this tool, and we'll send these slides out too, and the link is available at the bottom of this slide. But you are able to click on each hypertension threshold, and it will guide you through the recommended action, when to reassess that patient, and during reassessment, what those next steps should be if the goal for blood pressure was met or it was not met. And then bonus item number 1, have you had caffeine in the last half hour? If you have consumed a caffeine product within the last 30 minutes, you can give yourself 5 points for bonus item number 1. Another great resource is a competency checklist. So, this is a tool that can be used to observe technique in your staff, those that are responsible for measuring blood pressure. It includes all of the steps that we covered today, with 2 columns, whether that step was performed or whether it was not performed. So this is really helpful to go through with your staff as they're measuring patients' blood pressure, just to check and make sure that they are using proper technique. This could be used no matter what type of device. It identifies which steps apply, whether it's a manual, and automated, or both. So it covers, all the patient positioning factors that we covered today, and then also some of those manual technique steps as well. And we've included a link to the competency checklist in the chat. So thank you, Jerry. This is another great resource. A link to this is on this slide. But this is through the Target BP program, and it's another way to make sure that your staff are taking patients' blood pressures accurately every time. So just going through this checklist and making sure that each of these components was addressed or not. And bonus item number 2, have you smoked in the last half hour? So if you have smoked a tobacco product within the last 30 minutes, you can give yourself 5 points for bonus item number 2. And then quickly going into bonus item number 3, were you just doing moderate or high level physical activity? If you were physically active, you can add 5 points for bonus item number 3. So now it's time to add up your score. So take a look at the points you've hopefully been jotting down throughout this presentation. There were 7 scavenger hunt items, and then we had those 3 bonus items. And take a look at your total score. If you feel like sending that in chat, go ahead. But want to outline what each of these numbers mean. So if you want to think back to the slide where there were those bubbles, for patient positioning, that's really where all of these scavenger hunt pieces were coming into play. So I won't go specifically into each of these since I already covered them. But let's go over to the next slide. If you were having your blood pressure measured at this specific point in time and these issues weren't addressed, this could be how much your blood pressure could potentially be elevated. So would this qualify you for a referral to your primary care provider? Would this qualify you, maybe as hypertensive? So just think about that, how much those pieces of just how you were positioned today could have impacted your blood pressure. So hopefully this scavenger hunt has been a fun little game throughout our presentation for today. But I know I went through a lot of that information pretty quickly, but I think that is all the information that I have for you today. So I think we will go ahead and open it up for questions.
Thank you, Andrea. That was a great presentation. We do have one question from one of our participants, and from Andrea to Andrea. Andrea says that she has been taught that the diastolic reading is not a sound and is the disappearance of sound and not the last pulse sound before sounds disappear, as was mentioned as part of our slides. And she was just asking if you could expand on this, and she has a reference, and I'll put that in chat if it helps.
Yeah, great. That's a great question, Andrea. Yeah, it is the disappearance of pulse sounds. So you want to note where you last heard the pulse sound as you're using the manual method, and then note that pulse sound right after that. So that would be the diastolic number. And I am seeing a question to go back to the previous 2 slides. So hopefully these are the slides you are referring to. And we can include a link to these slides in the chat as well. I'm seeing a couple questions on whether these slides will be available. So we'll include a link in chat. I do see another question in the chat box. What about taking blood pressures on forearms if a patient's arms or legs do not fit the cuffs, or if they refuse to do an upper arm? So that's a good question. Like I said, the upper arm device is really the gold standard, but if that's just not an option for that patient, there are wrist cuffs available. I would say wrist cuff over forearm. There are wrist cuffs on the validatebp.org website, those are all devices that have been clinically validated for accuracy. So I can include the link to that in chat if you wanted to check any of those out, if that was needed for that patient. Again, like I said, blood pressure should really be taken on a case-by-case basis. But what I shared today was really mostly just the gold standard if you are able to do that on your patient.
And Andrea, I'm not seeing any other questions in chat right now. I did just want to say, and I'll put this in chat quickly too, is we'd appreciate it if everyone could make sure they take the post-event evaluation question there. That's always kind of nice. It helps us figure out where we can improve or what other sessions you might be looking for. So put that in chat here quickly. And as far as the slides too, I did put the link in chat, and I believe those were actually sent out to everybody who registered yesterday too, is my understanding. The other resource for these slides in this presentation is that this will be saved to our Superior Health Connect site, and also on our Superior Health website. It's on a YouTube recording, actually, is what you'll see when you go to our website. I want to make sure I'm not seeing any other questions. I did, Andrea, I was just going to add, I'm not sure who it was in chat, but when you were asking which arm to take the blood pressure on, I thought it was a very good point that someone had brought up about it not being a surgically compromised arm. And I know that's one thing too, as we deal with or working with a lot of our patients too, they might have fistulas if they're on dialysis, that type of thing. So I think that's something too that I'm sure everybody does ask, but just, making sure that before we're using an arm for blood pressure, that they don't have some reason an obvious reason that we shouldn't be using that arm.
Yep, correct. That's a good point, Jerry. Yeah, if a patient has had a procedure on, one side of their body, you want to make sure that you're using the other arm for blood pressure readings.
I'm seeing a lot of thank yous, and I'll just say thank you to all our participants too. I thought it's always helpful to have good questions and people participate and stay on for the whole webinar, which is always nice. So.
Yeah, and as Jerry said, this recording will be available. So if this is something that you want to take back to your staff that are measuring blood pressure, whether that be, nursing assistants, medical assistants, and you do have questions, I will be available in the Connect platform, and we can definitely communicate that way if you do have any questions. But I also have my contact information on this slide if you have any further questions.
We did just get another question here, Andrea. Who would you recommend for calibrating blood pressure cuffs?
Yeah, so I would recommend going back to your blood pressure device manual. Sometimes there is information on calibration in there. If it's a manual device, sometimes they do send tools to be able to do that on your own. But if not, I would recommend going to your device manufacturer and seeing if they have someone who could calibrate that device for you.
I think we have probably gotten to all of our questions. And I'll just throw it back to you, Andrea, if there was any last things you wanted to say before we close the presentation for today.
I think that's it from my end. I appreciate all of you joining for today. Like I said, hopefully you've learned some tips or tricks that you can take back to your practice or your facility and start implementing that, right now as you take patients or residents' blood pressure. So I appreciate you taking your time to spend with us today. And like I said, if you have any questions, I am more than happy to answer those in the future.